Welcome, everyone. My name is Dr. Alok Patel. Thank you all for being here. We have a very exciting and important conversation tonight about the diverse range of symptoms and management as it relates to menopause, and I'm honored to be joined here by our three experts. Our title today, From Hot Flashes to Sleepless Nights and Everything in Between, we're going to be talking about evolving strategies for navigating the full range of menopause symptoms.
Welcome to Menopause Minutes. In the United States, approximately 1 million women reach menopause each year. Most women enter menopause around the age of 52. However, symptoms usually start much earlier, when a woman is in her 40s, the perimenopausal period, and are often missed. Up to 80% of menopausal women experience one or more vasomotor symptoms, VMS. VMS affects patients' quality of life, causing physical discomfort, psychosocial and economic impacts, and sleep disturbances. The treatment landscape for symptoms associated with menopause includes both hormonal and non-hormonal therapies, with evolving evidence supporting the central role of the hypothalamic KNDy system on VMS and sleep and mood disturbances associated with menopause. Currently, there are no approved therapies specifically designed to address VMS in patients undergoing breast cancer treatment, leaving them without effective options. This gap highlights the urgent need for innovative treatments that can alleviate VMS, while also considering the unique challenges faced by women undergoing breast cancer therapy. Over the next 60 minutes, we will focus on overcoming critical challenges in menopause care. We'll explore the diverse range of symptoms associated with menopause and discuss evolving strategies to manage patients and to address unmet needs in menopause care. We'll also discuss how to navigate patient hesitancy, overcome barriers, and cover the latest treatment advances, including the role of the hypothalamic KNDy system. Our program will conclude with a live Q&A session where our expert panelists will answer your pressing questions. Stay with us as we navigate these critical topics to enhance our understanding and improve patient care in the management of menopause symptoms.
My name is Dr. Alok Patel. I'm a hospitalist at Stanford Children's Health. I also work as a journalist for ABC News. Personal note, there are many topics in the world that are not covered enough in media, and menopause is one of them. And I see like 9 nodding heads right now because you all agree with me. So let me introduce our faculty up here. You guys can just wave as I introduce you. We have Dr. Diana Bittner, who is assistant professor at the Department of OB-GYN and Reproductive Biology, Michigan State Represent, and is the co-founder and CMO of True Women's Health in Grand Rapids, Michigan. We have Dr. Mary Jane Minkin, clinical professor, Department of OB-GYN and Reproductive Sciences at Yale University in New Haven. And last but definitely not least, Dr. Stephanie Fabian, professor and chair, Department of Medicine at Mayo, and the Penny and Bill George director of the Mayo Clinic Center for Women's Health and medical director of the Menopause Society in Jacksonville. I also want to give a shout out to a patient advocate we'll hear from later as well, Wendy Gibson. So with that, a quick overview. So after the welcome and introduction, we're going to talk about diverse symptomatology with Dr. Minkin, then moving on to Dr. Fabian to talk about the complex pathophysiology of what we're talking about. And then extremely important conversation is about the interpersonal communication. The reason why AI will never replace physicians is because we have culturally responsive techniques in talking to people, which Dr. Diana Bittner will talk to us about. So with that, I'd love to pass it on to Dr. Minkin to talk about diverse symptomatology.
And what does menopause really look like? And we've all seen a few menopausal patients, I'll bet. And we're going to actually start first with showing you a video, a conversation between Dr. Diana Bittner and a patient that she knows who has been exhibiting many of the symptoms that we're going to be discussing this evening.
Hi, everyone. It's Dr. Bittner at True Women's Health here in Grand Rapids, Michigan. And I'm here with Winnie, who is willing to share her story around her perimenopause and menopause. Winnie, how old were you when you first started having symptoms?
Around 36 when I first started having symptoms, hot flashes, not sleeping well, tired, fatigue.
And would this interfere with your day or your life?
Yes, it did. The hot flashes did. You had a pouring sweats. Not such a good thing at work because, your whole body is hot and it's like, okay, I can't function. I definitely can't do my job and I'm trying to cool off.
And as I recall, you worked at an OBGYN office, right,
Yes,
at
I
the
did.
time?
Yes, I did.
And what did you hear the doctors telling patients about menopause?
There's no labs to check your hormones, but pretty much at a certain age, just a life of a woman.
Just something to deal with.
Yeah.
And did you talk to your mom? Did you talk to anybody else about this?
Talked to my mother. I can remember her going through menopause with the hot flashes. And again, that was just something that you had to deal with as a woman. Her doctors didn't provide her with any treatments or anything.
How else was this affecting you?
Really had weight going up and down, mood off. One of my providers thought I had anxiety and depression and was treating me for that.
Did you think you had anxiety, depression?
No, I didn't. But I didn't know why I was having the symptoms that I was having. So I just took her word for it. Yeah.
Sure. And did you ever think about hormones for you?
Did not think of it in my community. To get hormones, you'd had to be rich. Insurance didn't cover this type of thing as far as I knew.
That was your sense.
Yeah.
Yeah.
So I didn't think about it. Only heard about it because of working in the medical field. And then it was like the 50-50. Some providers say, yes, it's a good thing. And then others like, no, you shouldn't do it. It's not natural.
So now that you know a lot more about it and you're feeling better,
I feel better.
awesome. What do you want other doctors to know now?
Just a deeper dive into learning more about it, asking the patients more questions, and not treating them for symptoms. Treat them for what's really going on.
Which could be the perimenopause, menopause, right?
Yep.
All right, Winnie, thank you so much for sharing your story with us and being vulnerable and willing to tell those personal details. So really appreciate it.
Thank you for having me.
You're welcome. Okay, back to you, Dr. Minkina-Akag. Thank you.
And thanks to Wendy and Dr. Bittner for presenting that. And it's a very helpful introduction. And one of the things I hope that came across from the video is that menopause has many facets to it. And we're going to be talking primarily about the vasomotor symptoms today, VMS. And they are a hallmark of menopause to most women in the US. When they think menopause, they think hot flashes. They don't think of the other symptomatology. We're going to talk about good news and bad news. The symptoms are most pronounced during the first 4 to 7 years. This is one of those things that does tend to get better over the course of time. However, the symptoms, don't tell this to your patients, please, but they can persist for well more than a decade. And what's really at least interesting to me is that the prevalence and the exact symptomatology differ in different countries and within the US among women of different origins, different ethnic origins. And I keep trying to tell my medical students, this is why I try to trick them into becoming OBGYNs. I say, there's a lot of, Nobel Prizes here, and we can try to figure this out. And there are some other related symptoms that we deal with, including night sweats and significantly disrupted sleep as well. And unfortunately, this also, besides just being hot flashes, translate into adverse events in cardiometabolic health. So these are real problems that our patients are dealing with. Insomnia, of course, is one of the sequelae. It can be independent, but also one of the sequelae of the hot flashes. And sleep disturbances are among the most reported symptomatology of our women going through the menopausal transition, and very commonly associated with sleep disturbances. Now, of course, there are predisposing factors. Some people will tell you, your patients will come in, I've always slept terribly, but are you sleeping worse? Yeah. And it's a persistent condition of poor insomnia and aging by itself, of course, and those increase during the menopause. And of course, the risk of poor sleep is increased by symptoms such as hot flashes, the night sweats, mood disorders, poor health and pain, which all feed into each other. And whether the sleep makes those worse or vice versa, the patient's ending up with miserable symptoms no matter what. There are a lot of options that we do have. We're going to be talking about some of those this evening. There are medications. There are behavioral interventions. One of the very popular behavioral type things is cognitive behavioral therapy for insomnia. You'll see an abbreviation CBTI. They can be helpful. There is data showing that. And of course, menopausal hormone therapy we know works and should be considered for most of your patients as a possibility. Um, and yes, if you were wondering about this, there is a rating scale. There's a number for this, a technical rating scale for hot flashes. So you can discuss this with your patients. And this was actually about 20 some years ago that the FDA came up with their guidance for industry as far as how do you do a test, how do you do a trial for hot flashes. And you want to really be checking the women who are miserable. So their definition of miserable, we'll get to that in a minute. Mild is basically a sensation of heat without sweating. Moderate is, yes, the patient does sweat, but she can still keep doing what she's doing, activities of daily life. Severe hot flashes actually are defined this way: sensation of heat with sweating and causing cessation of activity, or as I say to my patients, it stops you dead in your tracks. Okay, that's a severe hot flash. And when you're studying a product for vasomotor symptom relief, that the participant to qualify has to have at least 7 hot flashes a day, moderate to severe hot flashes, not just mild ones, the moderate to severe ones, or greater than or equal to 50 hot flashes, moderate to severe ones a week. And there, yes, is a formal questionnaire on this called the Work Productivity and Activity Impairment Scale questionnaire. And this is actually used to, and we're going to talk a little bit more about this, to study the impact of hot flashes and night sweats on daily and or working activities, because there are significant implications on both from hot flashes. Again, this is not just hot flashes. These are real things, okay? Now we're going to go back to some more data from the study of women's health across the nation, which is how we got the data on different ethnic groups and stuff. So if you look at the average duration of hot flashes, we're talking about overall for the US population, 7.4 years. And no, it's not a quiz on this afterwards, don't worry. But I alluded to this already as far as the difference in ethnicities. And this is again from SWAN data. In Japanese women, the average duration is about 4.8 years. Chinese women, 5.4 years. Caucasian women, non-Hispanic folks, 6.5 years. Hispanic women, 8.9 years. And unfortunately, African American get the worst suffering. African American women, the average is 10.1 years. Again, why does this happen? We don't know. A few more Nobel Prizes out there if you're looking for them. Okay, what else can influence vasomotor symptoms besides your ethnic background? Well, smoking. And I always tell my patients who are smokers, and I try to be a little persuasive, some of you know, well, you want to go through menopause 1 or 2 years earlier, take up smoking. You will go through menopause. Smokers have menopause about 1 to 2 years earlier than non-smokers. And by the way, also, if you want to try to convince people to stop smoking, that not only do they go through menopause earlier, but they tend to have more severe hot flashes. So another good fact for you. And again, they do experience more hot flashes, severe ones. Obesity. We used to think that significantly overweight women would benefit by the presence of more estrogen produced from the aromatization of their androgens, but significantly overweight women, if you look at the actual data, actually suffer from worse hot flashes, not better hot flashes, not because they have more estrogen or anything like that. The theory behind that is that heat is generated centrally, and with the more adipose tissue there, the heat doesn't get dissipated as readily, and they get hot, their core heats up. And then, of course, we have to talk about iatrogenic causes. And hysterectomies are not just, a surgical procedure, but they accelerate the age of menopause by an average of 1 to 2 years. Okay, that's leaving the ovaries intact. Okay, just women who have hysterectomies, whether it's deviation of blood flow, et cetera, we're not really sure, but they tend to go through menopause 1 to 2 years earlier. So do take that into account when your patient tells you you didn't think she was going through menopause. Well, it makes it a little earlier. And of course, ovarectomy, if we take out the ovaries, causes the sudden loss of estrogen, leading to more intense hot flashes. And again, particularly if these are for younger women. Wait, there's more. That if we do these iatrogenic changes to a young woman, she's coming from a relatively high level of estrogen. Not that the older ladies don't have any estrogen, but they have less relatively. And the younger woman may experience more hot flashes, more intense hot flashes than the older women. And there are other causes besides just taking out their ovaries that basically we can destroy. We can do this, the iatrogenic folk, we can destroy ovarian tissue from radiation therapy or chemotherapy. One of my special interests is in women who have cancers. And occasionally ovarian function, particularly with chemo, not in general with radiation therapy, but it will return, but often it does not. And again, part of that's related to the age at which the woman is experiencing these iatrogenic changes. And of course, one of the problems that many of you are well familiar with, particularly with breast cancer patients, but oftentimes some gynecological tumors, as we deal with, that estrogen may be contraindicated. So what do we do for these women? You know, they're still in suffering, but how are we going to help them? Okay. And unfortunately, that the medications that we have for vasomotor symptoms, besides estrogens, do have many potential side effects. For example, something that many people don't realize is some of the SSRIs, which are known to be helpful for hot flashes, in a sense, mostly off-label usage, fluoxetine and paroxetine, they are not recommended for use in women who are on tamoxifen because of interference with CYP2D6. And then, of course, if we give women aromatase inhibitors, that leads to increasing achiness and worsens VMS, something else to be in account for when these women are dealing with hot flashes. And of course, if we give these women gabapentin, because maybe they have some pain or achiness or neuropathies, they'll cause sedation and bloating. So we don't have a lot of ideal options. We have options, but many of them are unfortunately far from ideal for these women. And then what's else going on with the VMS? Well, unfortunately, we've talked a little bit about this with the diminished quality of life in women secondary to the vasomotor symptoms. And again, the vasomotor symptoms leading to poor sleep, fatigue, anxiety, and depression, things we don't want our patients to be suffering from unnecessarily. And again, hot flashes are more than hot flashes because, again, these symptoms can lead to things like social withdrawal, and there's plenty of data on that, feelings of embarrassment, strained relationships, problem with work, and we're going to talk about that in a minute, and difficulty managing simple daily tasks. So again, these are more than just, oh, she's just having hot flashes. And for example, there is data on how much does it cost. In America, we're concerned about how much does it cost. We should be. But untreated vasomotor symptoms, there is data, and these women had significantly higher healthcare costs because of resource utilization. That basically data showing that 82% higher rate of all-cause outpatient visits in women who have severe hot flashes, moderate to severe hot flashes, to compare to the women that don't. And also, there's indirect work productivity lost from the hot flashes to the tune of like 57%. Of more indirect work productivity loss days than in the control patients. So again, hot flashes translate to other stuff more than just hot flashes. And indeed, there are fancy scales and stuff like that, menopause rating scales, and basically examining women who are 45 to 60 years old. The mean MRS score was a moderate menopause symptom burden. But if you break this down, that women in the highest quartile of the MRS scores were 15.6 times more likely to have an adverse work outcome than the women in the first quartile, the women who don't suffer from hot flashes. So this can impact people's quality of life, also their quality of work, which really is very sad and very depressing for many women. Okay, and we want to get these women treated because they want them comfortable, but also from an economic perspective. There's nothing else that's better for economics here. And just to bring this back to being at ACOG here, the menopause transition is a pivotal stage in life for individuals. This is an article coming from the March Green Journal, assigned female at birth, characterized by a range of physical and psychological changes. This is directly from the article. And for those women who are in the military, this was looking at military service among women, that this transition may be further complicated by service-related factors. And indeed, I was not aware of this act until I read the article in the Green Journal. All read your Green Journal, it's very important, that this is a direct quote from the Women Armed Services Integration Act of 1948. That restricted the number of women who could be promoted to leadership roles in part because of concerns that women eligible for senior positions will be at the age of the menopause transition, which could lead to making irrational decisions. You like that? That's there. It's, so is it all in your head? Yes, I will make a statement fact there. I always encourage my patients who are suffering from severe hot flashes and insomnia when they are told in a disparaging remark by their partners, it's when they say it's all in your head, I just tell my patients to smile sweetly and point to the bridge of their nose and say, yes, dear, it is all in my head, right here in my hypothalamus. So use that one, take it, you don't have to give me attribution. So anyway, so we'd like to throw this open for some questions to Dr. Patel.
So this first table, you guys have been engaged, and I want to toss this first question over here. And that's going to be about what symptoms do patients usually come to you when it comes to menopause? Like, what symptoms have you heard?
Definitely the hot flashes and insomnia and irritability.
Anyone else?
Menopause belly.
Any other symptoms?
I would say maybe menopause belly means abdominal bloating, and then also a lot of night sweats.
A lot of night sweats. And so we have heard about this diverse range of symptoms, and if anyone goes and searches menopause treatment, obviously this whole host of treatment come up. So I want to ask this table now, what have patients tried before they come to see you for your expertise?
And different kinds of special diets, especially if you're from the Asian origin, people, they try a lot of different mixes of spices and all that, and then they come back and say nothing is working.
Anyone over here for something that patients have tried that you've heard about?
Some of the lifestyle things like using a fan at night and stuffing ice packs everywhere that they can.
Practical tips. Let me toss it now to Dr. Fabian to kind of run us through this complex pathophysiology and why this all might be taking place.
Got it. All right, next we're talking about decoding the complex pathophysiology of menopause symptoms. So let's just start with some background here. I don't know if you guys remember 2002 when the Women's Health Initiative came out, but before that, about a quarter of the women in the United States were using systemic hormone therapy. It was one of the most commonly prescribed drugs, bar none, even more than antidepressants. And when the study hit, hormone therapy usage rates plummeted by orders of magnitude. And this study that was just published last fall is the first study to have come out since the data from 2011, 2012, when at that point, the usage rates were between 4 to 6%. So I was thinking, gosh, this is going to be great news because we're talking about menopause. The rates are going to be up. It's going to be higher. No. What is it? 4.7% in the United States right now. And here's the kicker. This study couldn't even distinguish between systemic hormone therapy and vaginal hormone therapy. So 4.7 is both systemic and vaginal. Women are not using it. The biggest declines, well, Black women are under 1% right now. Greatest declines were in women that should probably be using hormone therapy, those aged 52 to less than 65. So let's just say we've got an issue with menopause management in general in this country. What is hormone therapy indicated for? Well, a few things. Vasomotor symptom management, it is considered first-line therapy. Even my colleagues in my own institution will often give an SSRI as first-line therapy. And I'm an internist, by the way. So we are trying so hard to change this message here. But VMS management, first-line therapy, genitourinary symptoms of menopause, we have plenty of evidence that hormone therapy helps actually reverse the changes of menopause. Prevention of bone loss, not treatment of osteoporosis, but prevention of bone loss and reduction of fracture risk. And then treatment of premature hypoestrogenism, so premature ovarian insufficiency or bilateral oophorectomy before the natural age of menopause. Those are the 4 indications for the use of hormone therapy. Who is the best candidate? Well, it's women under the age of 60, and we'll talk a little bit more about why that is, or keep in mind the or here, it's not an and, less than 10 years past menopause. The reason it's not an and is if you get a woman who goes through menopause at 58 and she's now 61, she's still a candidate for hormone therapy, okay? So you count the 10 years after the onset of menopause. Bothersome symptoms, that goes without saying, but let's keep in mind that women don't always just have hot flashes. It almost always is a combination of hot flashes and other symptoms, mood disturbances, sleep disturbances. Dr. Minkin talked about the joint aches. We are now learning that joint aches are one of the most commonly reported symptoms related to menopause. Bone density concerns, personal preference to use hormone therapy, no excess cardiovascular or breast cancer risk. We'll talk a little bit more about that. And no contraindications. What are contraindications, you may ask? I kind of laugh about this first one because it shouldn't even be on the list, in my opinion. Unexplained vaginal bleeding shouldn't be unexplained. We should be able to explain it. So we should be able to take care of that one immediately and wipe it off the list. Then we have prior estrogen-sensitive cancers, breast or endometrial, history of stroke, heart attack. Dementia actually isn't on the list anymore because if you think about it, we could have a woman with early onset dementia. It doesn't mean she's not a candidate for hormone therapy. History of or inherited high risk for venous thromboembolism and severe active liver disease. So if you look at this list, it's actually a small list. There's not a whole lot of women who have absolute contraindications to the use of hormone therapy. I'm not going to spend a lot of time on the WHI, but here's what I want you to know. So this was absolute risks and benefits from the WHI in women who started hormone therapy between 50 and 59 years of age. So those younger women. This is the number of events per 10,000 women per year. So if you look at all this whole graph, these are very small numbers. There are small numbers of risks and benefits, okay? So just keep that in mind. Estrogen alone trial is the top bar. The estrogen plus progesterone trial is the bottom bar. And if you look at the estrogen alone, generally more benefits than risks. And if you look at the lower one, a few more risks, but we still have significant benefits here as well. I want you to look at breast cancer specifically. Estrogen alone, 5 fewer cases of breast cancer. That's not a mistake on there. It was associated with a lower risk of breast cancer compared to sugar pill alone. Whereas in the combo trial, 6 extra cases. We'll talk about what that actually means for patients, but it is small increased risk overall. We do have benefits in terms of all-cause mortality, reduced fracture risk, and reduced diabetes risk from both arms. All right, so let's talk about how you should think about this in the office. Total risk-benefit profile, think about past medical history. We now know that most women in the United States are not 50 years old without any chronic medical conditions. 80% of women 55 and older have at least one chronic medical condition, and 50% of them have 2 or more chronic medical conditions. So it is most likely that you're going to walk into the room and there's going to be stuff. They're going to have something. So think about their cardiovascular risk overall. You can use an American Heart Association cardiac risk calculator. It's easy. You pull it up online. It takes about 2 seconds to run that calculator. But in general, you want to make sure that their risk factors like high blood pressure is controlled before you're starting hormone therapy. Think about their age, their time since menopause, and think about if they have bothersome symptoms. I can pretty much promise you, if they've made it all the way to your office to talk about menopause symptoms, that their symptoms are bothersome enough to get to you. Because think about it, they had to make that appointment, they had to call, they had to get off work, find a babysitter if they have kids at home, find somebody to sit with their aging parent if they have an aging parent at home. It took probably 6 or 8 weeks to get in to see you. They still showed up there. So patting them on the head and telling them it's probably not so bad, I'm sure you don't need anything, which is what my internal medicine colleagues will often do, is not the right answer because they made a big effort to get to you. They're probably bothered by their symptoms. And talk about their willingness to tolerate risk for treatment, although we talked about the fact that risks and benefits, the risks are fairly low for most healthy younger menopausal women. All right, so this is how you go through it in your office. Age, time since menopause, make sure they don't have a contraindication, sort of look at their cardiovascular risk factors. If they have low ASCVD risk on the calculator or less than or 1 risk factor, they can use anything. They can use oral estrogen, transdermal estrogen. If they're in the intermediate risk category between 5 to 10%, 10-year risk of cardiovascular disease, or they're low risk but they have 2 or more risk factors, you consider transdermal estrogens, generally a safer way to go. Through the skin and through the mouth, you avoid first pass metabolism through the liver, lower clot risk, lower stroke risk. And then if you're in the red category for any of this stuff, we generally start thinking about other things other than hormones, so non-hormonal management here. This is for your reference only. I'm not going to go over this, but the point here is that there are lots of systemic estrogen preparations out there on the market. When might you need a progestogen along with the estrogen? So we need that for women who have a uterus. It's to prevent growth of the endometrial lining, prevent endometrial cancer. There can be some adverse effects from a progestogen, including can cause bleeding. It may increase mammographic density, may increase breast discomfort. The WHI showed a higher incidence of breast cancer. We talked about that with the combo, but it did not show a greater mortality related to the combination. We have a TSEC, which is an estrogen. It was conjugated equine estrogens plus bazodoxifene. So that is an alternative to a progestogen, helps protect the endometrial lining. That was not associated with a change in breast tenderness or breast density or endometrial thickness. And keep in mind that right now we do not need a progestogen along with local vaginal estrogen therapy alone. Here's a list of some of the progestogens out there. Again, this means you have lots of options available to you. Here are the combination therapies, again, for your future reference. All right, over-the-counter products. As we heard, we have our patients are trying all kinds of things out there, all kinds of supplements being recommended to them. There's a lot of false advertising going on out there. Here's some of the things that women are using out there. You'll see I listed cannabinoids. To date, there is no evidence that any of these things are effective against hot flashes. All right, what has been proven to help with hot flashes? We know cognitive behavioral therapy is effective. It doesn't stop the hot flashes from coming, but it reduces the bother and interference associated with the hot flashes. Clinical hypnosis has some data. It reduces frequency and severity. We actually know that weight loss helps. This was in the Women's Health Observational Study and a couple of additional smaller studies that are out there. And then stellate ganglion blockade, invasive, not going to probably use it for the run-of-the-mill patient. Here's a list of non-hormonal prescription therapies for vasomotor symptoms, and this is from the 2023 Menopause Society non-hormone therapy position statement. It's a nice list. As you'll notice in the SSRI and SNRI category, you don't have to use super high doses here. We're talking fairly low doses of the SSRIs and SNRIs. Please keep in mind, though, that these are not nearly as effective as hormone therapy. Hormone therapy will reduce vasomotor symptoms by like 90 to 95%, and we're generally talking about a reduction of 40 to 50% for SSRI, SNRI. Gabapentin sort of in the same category, and as Dr. Mencken already alluded to, you have difficulty with sleepiness, but also weight gain. Midlife women do not want to gain weight on these therapies, and if you give them something that's going to make them gain weight, they're not going to be happy with you. And then not advised is that bottom list, and you'll notice that we moved clonidine down into that list. That used to be in the recommended list, but it's got so many side effects associated with it that it's really not recommended anymore. All right, it was really just about 10 years ago when we used to answer people when they asked what causes a hot flash, we go, we don't really know what causes a hot flash. How embarrassing is that? But Naomi Rance did some really, really elegant work here in a mouse model and ultimately found that group of neurons called KNDy neurons that are responsible for the hot flashes. That's kisspeptin, neurokinin B, and dynorphin. And what happens is when the brain isn't hearing from the ovary anymore, those neurons are overactive. They are screaming. And we know that that hyperactivity of those KNDy neurons causes hypersecretion of neurokinin B. When you block the neurokinin B receptor, hot flashes are reduced. So this was really a hallmark. This led to future development of a new drug. So fezolinetant, Skylight 1 and 2 trials, phase 3 trials, these were randomized placebo-controlled trials. They looked at 2 different doses of fezolinetant. Both of the doses significantly reduced VMS frequency and severity at 4 and 12 weeks. And this drug was ultimately approved at the 45 milligram dose once a day 2 years ago now. There was a boxed warning on the label as of December. It occurred because of a case of liver toxicity that occurred at about 40 days of treatment. Now there's a recommendation to check the liver test at baseline, 1 month, 2 months, 3 months, 6 months, and 9 months. So adverse effects, headache was the most common, others abdominal pain, diarrhea, insomnia, back pain, and oddly enough, hot flashes. Elinzanetant, an NK1 and NK3 receptor antagonist under development, also was shown in randomized controlled trials to reduce VMS frequency and severity at both week 4 and week 12. It also showed improvement in sleep and improvement in menopause-related quality of life, adverse effects, headache, fatigue, arthralgia. No liver toxicity was noted in the original trials. Another study, OASIS 4, that also was with elinzanetant, looked at the efficacy and safety of this drug in women with a history of breast cancer who were on tamoxifen or aromatase inhibitors. And as you can imagine, this would be an ideal group who could use a non-hormonal therapy. It showed that it works in this population as well. And so and we know they have increased risk of hot flashes, especially those on aromatase inhibitors. So what's the implication of having two receptors blocked instead of just the NK3, NK1, and NK3? Well, we know that NK3 receptor antagonism reduces vasomotor symptoms. NK1 antagonism promotes sleep, but also helps with vasodilatation. So it may be synergistic with the blockage of the NK3 receptor. So these two may work together and cause improvement in both sleep and VMS. Also, this is just a fun note because I did a lot of digging in the literature when I was like, how do these things work? What's the whole story here? And I found that Naomi Rance actually found that in the mouse model, it's also been shown to reduce visceral fat accumulation associated with the loss of estrogen. And would not that be the perfect drug if you could actually have sleep, hot flashes, and weight management with one drug? But I'm not saying that it's being considered for that reason, but more to come. All right, so what are the implications for practice here? We've seen a notable decline in hormone therapy use, especially in those women who probably could be using it. And we have a critical need for education of clinicians about current evidence-based practices, hormone therapy treatment for menopause symptoms, considered first-line therapy. Your best candidate for hormone therapy is less than 6 years of age or less than 10 years past final menstrual period with bothersome symptoms and a desire to use hormone therapy. And if a candidate or if a woman either doesn't want to take hormone therapy or is not a candidate for it, we have lots of non-hormonal options available. So with that, I'm going to turn it back to Dr. Patel.
Show of hands. Who here has talked to patients, to women who are hesitant to use hormonal therapy? Good amount, good amount. What are some reasons why? Just holler at them at me.
They think they're going to get breast cancer.
I think they're going to get breast cancer. You had your hand up too.
Yeah, they think they're going to get breast cancer.
Is this a reason other people have heard as well?
Personal history of cancer, family history really kind of prevents them from getting hormone replacement therapy.
In order to get this information out of people, we have to have culturally competent care. I want to pass it over to Dr. Bittner now, which I feel is an extremely important part of this conversation. That's having culturally responsive, tailored care. Dr. Bittner, please.
Thank you. I want you all to think about why you're here tonight, right? You might be more curious, you want to add to your knowledge base, or you might really want to adjust your clinical practice. So we're so glad you're here. And I've had many comments from colleagues that say, well, my patients don't even talk about it. So we're going to talk tonight what actually happens. And I pivoted from being a generalist after 20 years in practice because I couldn't unsee the effect of menopause, the symptoms, the health consequences. So we're going to dig into that. So there are many factors that drive patients to not seek care. You heard some of those from Winnie. And we're going to use a model of health-seeking behavior, why people will seek care or not. So first of all, why do women suffer in silence? Mindset is a big deal. So in a great study done by Gloria Richard Davis, she used 3 different survey tools and found that some people don't ask for care because they think it's just natural and I need to tough it out. Or maybe they even heard from a provider in the past of, honey, you just got to get through this. And I had a patient who said this to me last week. She was told that by her provider. Sometimes there's not access to care in terms of financial, transportation. Like Winnie said, her community said that to get menopause care, you had to be rich. And of course, is there an availability of a menopause expert? There's 6,000 patients a day who go into menopause in the US, and there's only 3,000 approximately certified menopause providers. We're working to make more of those trained and get them out there. There's also a lack of awareness, like patients are concerned or women are concerned, you know, are there treatments that are actually safe? Or like you said, I have a family history of breast cancer. So there's a lack of awareness and people are afraid to ask. There's inadequate training. Jewel Kling did a great study years ago. My institution was the site for that and found that around 10% of graduates, including from OB residencies, were not comfortable talking to patients about menopause. And there were several questions in that questionnaire about whether or not they would give hormones in certain instances, and they didn't score well in that test. So we have a lot of work to do. Also, if you don't have a knowledgeable mentor, right? If you go through training, especially if it was in the early 2000s, and there was fear-based practice around because of the WHI, if you weren't taught to use treatment for menopause, then you're probably not going to teach others or take that to your patients. And of course, lack of support. So like Winnie shared in her community, one didn't ask about menopause, and even once she worked at the doctor's office, she wasn't asking about that. So let's think about the impact. Again, if we don't ask, patients might not tell, but many of them, if you heard tonight, are having hot flashes and night sweats, 80% of people. It can really affect the quality of life. So I think about like a typical patient. She might be up with night sweats, and is she gonna feel like getting on the treadmill at 5:30 in the morning? No. So it's gonna affect her quality of life, her motivation to engage in those healthy habits. If she doesn't sleep well, it might increase brain fog, right? That constellation of symptoms that lead to poor cognitive function, not feeling like yourself at work. So again, your self-image as a viable, important part of your work community, that might go down. There's also issues with joint pain and sexual health. And so in terms of engaging in that activity that makes you feel vital and young and connected, that can really be affected. And of course, we've heard already, there's a huge cost to economy and personal cost in terms of career advancement. We know that about 10% of women leave the workforce in menopause. And of course, that really can affect a woman's independence as she ages. In terms of unhealthy aging, there are a lot of metabolic consequences. I heard a question about the menopause belly or belly fat. And it's really fascinating how loss of estrogen really does affect insulin sensitivity. So there's some great references here for you to check out later. But an interesting study showed that women tend to be protected from insulin resistance until they lose estrogen. But if they choose to take menopause hormone therapy, that insulin sensitivity is often restored. So we know that MHT actually reduces the risk of type 2 diabetes in women who take it over a study that showed over 20 years consistent result. Of course, it helps with bone support, and it helps with mood and cognitive function in the sense it can help us sleep. So Dr. Thurston has done some critical work around this, looking at WASO, or waking after sleep onset, but also looking at those physiological hot flashes that happen that we might not be aware of that can actually increase hyperintense signals in the brain that can signal small vessel disease and an increased risk for dementia. And of course, osteoporotic fractures, we know if our older patients have fractures, the risk of death is not small in the year after that fracture. And again, impaired career advancement or early retirement. I have many patients who say, I'm worried that I have to quit my job because I don't feel as sharp. I feel like I'm letting my team down. That again can change outcome and lack of independence. So what do we do about this? Number one, if you're comfortable talking about menopause, you've got a working knowledge, or getting started in this, advertise to your community, market to them. When I started in this 15 years ago, I gave free talks everywhere, right? School, police officers, teachers, whoever would have me, I would go talk because it got the word out. And I learned so much from the people in those audiences. Join the Menopause Society, become a certified menopause practitioner. There are a lot of resources that can help guide your practice in the office, that can help. I work with employers and how they can work with their employees. Women just want to be able to control the temperature and ask for some flexibility and be comfortable talking about this at work. So again, we've got to get out there with this information. And if us as science-backed providers are not out in the community, they're not going to listen to safe evidence that could actually help them. In my practice, we provide a pre-visit packet with an example vignette. We give a lot of examples about women going through this perimenopause, menopause, and a questionnaire that, again, lets them know that it's safe to talk about menopause in our practice. Also, it's very important to normalize the conversation, but to establish their phase of ovarian function using the STRAW plus 10 criteria. There are symptom inventories that are validated, the MRS, the MTS, the MENQUAL. These are validated tools that can allow you to even track their progress depending on what therapeutic that they choose. The PLICIT is something you might have heard of, used to help us talk to patients about sex, about sexual health. I really use this a lot in talking about menopause. So PLICIT starts with P, permission. We have to give people permission, right, to talk about this. And I might say to a patient, many women wake at 2 a.m., can't sleep afterwards, or many women have symptoms of menopause and don't talk about it, right? So then we're giving permission to start the conversation. And then we listen, but give limited information. Waking is caused by night sweats, low estrogen levels, makes your thermostat more sensitive. Let's figure this out and see what you want to do. So again, just a little bit of information to hopefully get them talking more about their experience, because again, it's different in everyone. And then we talk about specific suggestions. You're in early menopause, you're less than 5 years from your last menstrual period or the onset of menopause. And these symptoms could last another 3 to 5 years, depending on your background, your culture, your ethnicity, and can affect your health and your quality of life. There are treatment options. Would you like to talk through these? We give an informed consent sheet. We talk about all the different options and let people really see what their options are. And again, intense therapy. It's really okay to say, I don't know much more. I'm not very comfortable with this. I deliver babies. I do surgeries. You know what? Would you see my colleague who's a certified menopause provider? So that intense therapy, if that's not in your comfort zone, then it's okay to refer to menopause.org, to ishwish.org. There's a lot of institutions that have really great tools for you to use. So I can be your doctor through this phase of life, but I'm going to refer you to my colleague who knows more than I. It's okay to say, I don't know. So again, empowering healthcare professionals. How can we do a better job of taking care of patients? I mean, for goodness sakes, no women will escape this. This is an equal opportunity condition, right? Just like puberty, we're all going to go through menopause. My youngest patient so far is 15, who had menopause from a Wilms tumor and radiation to treat that disease. So again, we're all going to have this. We need to do a better job. So we've got to prepare and educate healthcare providers. Unfortunately, your work units might suffer if you go to the hospital and give a lecture to the residents, but maybe it's worth that sacrifice. Take the time, educate other learners. Recruit or become a certified menopause expert yourself. And again, we all need to decide our role in this. Either do it well or don't do it. But validate your patient's experience and refer or get educated. I definitely endorse, please, to your SOAP note, say she's a G1, P1, early menopause, or late perimenopause, or early perimenopause. Right away, it just sets up the conversation for you in the future and for your colleagues. And then practice how to present treatment options. So many colleagues will say, well, I don't know how to talk about this. It's going to take an hour. I don't have time for this in my busy day. I get it. But practice. Know how to talk about it in a very simple way. Have a handout ready to go. Again, the Menopause Society has wonderful tools that are free. And so you can use these tools to be comfortable. So again, there are tools. Again, what are those frameworks? Ask about their symptoms. It's okay if you don't have all the answers. Say, hey, I have colleagues that will help me. You can call any of us. Let us know if you need help. Like, if I don't have the answers, we'll get them. But have a process. Again, communicate that this is a life phase. Nothing is wrong with them. They don't need to be fixed. This is a life phase, but there are options to help them feel better and age as they wish. Again, validate that changes are real. Offer treatment or offer informed consent. And then again, create events. So maybe you go on TV, you go on the radio, you do an article in the newspaper. Again, think how you can get the word out there. And now throwing it back to Dr. Patel, and he's going to ask you some more questions.
What can we do to create more menopause-friendly clinics, environment? What can we do?
Yeah, I mean, I think all the things that they're saying tonight, but obviously education is key. I think it's a little bit complicated because of social media, and you have to be able to weed through, you know, all of the noise there, but education of providers is critical.
This table up here, does anyone else have a quick thought about what we can do to create a better conversation and make practices more menopause friendly?
Perhaps you can form community groups and forums in local communities where a lot of the women are going through the same things to perhaps begin the conversation. And all women know that they do go through it. So I guess getting the community together to help encourage them to seek to go through it together.
Community directed approach. I love that. Let me toss it back to my panel.
Key takeaways. Okay. The key thing is that most patients will be bothered to a greater or a lesser extent by hot flashes, but there are finally available treatments for just about everyone.
So menopause symptoms are bothersome, and we've already demonstrated that they are largely untreated, but we have lots of options. So the correct response is never going to be, we don't have anything to offer you. So we have hormonal, non-hormonal therapies, and work with your patients to figure out what's going to work for them. What are they willing to take, and what's going to be most effective?
And the last one, that again, decide your role. Like after tonight, even, I hope you're really encouraged that you can do this. You know, this is something that can be very straightforward. Just practice. You can get it down to a shorter conversation, at least to get the conversation started. So just again, decide your role. Are you going to do it well or don't do it? Validate it and refer, but make sure that the conversation gets started.
So as we wrap this up, we have a few minutes left. I'm going to really slowly walk back to this stage. I'm going to put a microphone towards tables, and I want you all to yell out. What are some takeaways to improving menopause care? What have you learned from this session?
Patient education.
Patient education. Great one. Professional education. Non-estrogen alternatives.
Validate patient's concern.
Validate patient concerns. You guys got the assignment.
Non-hormonal options.
Non-hormonal options.
Easy access to medication.
Easy access to medication. This table.
Don't hesitate if the woman is more than 65.
Important question is, how do you address cognitive symptoms? How do you three manage it in your practice?
Do you want me to start with that?
I can.
Well, so you have to think about, why are cognitive symptoms happening? And so a lot of women describe this thing as brain fog. And this is like a really common description. Like when I started hearing it, I was like, what do they mean? Every woman knows what they mean when they say brain fog. But it's associated with falling hormone levels. It's associated with poor sleep. It's associated with poor mood. So the things that we can fix in there: treat the hot flashes, treat the sleep disturbance, treat the mood disorder. We don't know if that's going to fix the cognitive symptoms, because guess what? No one's ever studied that. But we can treat those things that we can treat, and we believe that that will probably help with this complaint of brain fog. We do know that brain fog is not a precursor to dementia, and you can reassure your patients that it does not seem to predict or portend the onset of dementia. So that's the good news.
One thing that I would like to add, again, getting into the dementia issue, is many people are now coming to us, menopause experts, whatever, as far as requesting estrogen for certain health issues. And we certainly have, and this is for your patient who goes through menopause at average ages, like 51.2 years, whatever, or anything later than that. But the key thing is that we have very good data that shows that estrogen helps prevent bone loss. We've got that data, no question about it. As far as heart disease, we have some experimental data. However, the one thing that we really do know is that we don't have great data to show that estrogen therapy to a woman who's of average age at menopause will help prevent dementia. So if your patient's coming in to ask that, you say, I don't know, I don't got data. Okay, I think we got data to say it's probably not going to make it worse, but we don't have a lot of data saying that it's helpful for that. So I think we have to be realistic in what we tell our patients as far as what certain things can do. And I can only double emphasize what Dr. Fabian has said about sleep, that people who don't sleep don't think so good. I mean, that's why we've restricted resident hours, because we knew that they were not sleeping. But the key thing is, if we can get them sleep, their brains are going to work a lot better.
Well, and I think a tool right in the moment, when they're having that brain fog, there's a lot of data around the power of gratitude, and that feeds into the whole how CBT can be very helpful for hot flashes and how to deal with them. So in the moment, let's say they're walking into a meeting with their boss, or they're walking in to give a talk to their team or have a difficult conversation, even just to stop, look away, stare at a spot, and think about what they're so grateful for. This is great work from Dr. Benson at Harvard years ago. Shows that gratitude in that moment allows them to reactivate their frontal cortex, lock into what they were going to say, and then the brain works. So again, just in that moment, to have a quiet space, to tell themselves they're okay, be grateful, and do what they got to do. It can also help get back to sleep in the middle of the night. But it's those little tools. At the same time, we're treating for the underlying cause, but we're giving them something to do in the moment.
Thank you all. Thank you all so much. Amplify, tell patients stories, advocate. Thank you, everyone, for being here.
Good job.